Today's drug comes from a flower. Scopolamine is extracted from belladonna, the same plant women once used to dilate their pupils for a fashionable, wide-eyed look centuries ago. It's also known as hyoscine. And out of every anticholinergic you'll use in practice, this one behaves the most differently from the rest. Atropine speeds up the heart. Glycopyrrolate dries secretions and stays out of the brain entirely. Scopolamine does something neither of those drugs do well. It puts people to sleep. Let's figure out why. The structure that explains everything. Here's the one fact you need to hold on to for this entire drug. Scopolamine is a lipid-soluble tertiary amine. That single structural detail predicts almost every property we're about to cover. Being lipid-soluble and uncharged at physiologic pH means scopolamine slides across the blood-brain barrier with ease. Once inside the brain, it competes with acetylcholine for muscarinic receptors, blocking them the same way atropine and glycopyrrolate do in the rest of the body. But because so much of it reaches the CNS, the picture that emerges looks completely different from a typical anticholinergic. What happens when you block those receptors? Wherever acetylcholine would normally act on muscarinic receptors, scopolamine gets there first and shuts the door. The downstream effects: secretions dry up, gut motility slows, heart rate creeps upward, though more modestly than you'd expect. Pupils dilate, and because so much drug is sitting in the CNS, the patient gets drowsy. How the body handles it. Scopolamine spreads widely. Volume of distribution sits around 100 liters, which tells you it's not staying confined to the bloodstream. The liver does most of the metabolic work. Elimination follows a two-phase pattern, with a half-life landing around 4.5 hours. Hepatic clearance runs about 1 liter a minute, while the kidneys only handle roughly 70 milliliters a minute, and only about 6% of a given dose shows up unchanged in urine. One practical limitation: you basically never see this drug given by mouth. Swallow it, and there's no telling how much actually gets absorbed, anywhere from 10 to 50%, which is far too unpredictable to build a dosing strategy around. That's why it's given IV or through a skin patch instead. The one job no other anticholinergic does well: sedation. Here's what makes scopolamine genuinely unique in this drug class. If you gave atropine at a typical pre-medication dose, you'd barely notice any change in the patient's alertness. Give scopolamine at that same kind of dose, 0.3 to 0.5 milligrams, IV or IM, and the patient gets sleepy. The reason comes back to potency at a very specific target: the reticular activating system, the brainstem network that keeps you conscious. Scopolamine hits that system roughly 100 times harder than atropine does. Beyond just making people drowsy, it also produces genuine amnesia, affecting memory circuits beyond the arousal system alone. And it doesn't just sedate on its own. It amplifies whatever else you've given alongside it. Pair it with an opioid or a benzodiazepine, and the sedative effect compounds significantly. That combination has history behind it. Back in 1900, pairing morphine with scopolamine became one of the earliest standardized approaches to preoperative sedation, sometimes remembered as twilight sleep, and it stuck around for decades before modern sedatives took over. Drying secretions. Scopolamine doesn't just outperform atropine on sedation, it beats it here too. Milligram for milligram, it's roughly 3 times more effective than atropine at shutting off secretions. So when a case calls for both a dry airway and a calm, sedated patient, scopolamine covers both needs in a single drug. And here's the part that trips people up. At doses matched for equivalent antisialagogue effect, scopolamine, 0.3 to 0.5 milligrams IV, is actually less likely to bump the heart rate than atropine at 0.4 to 0.6 milligrams IV. A drug that's far more potent centrally turns out to be gentler on the heart. That contrast is exactly the kind of thing exam writers love to test. Preventing nausea. Outside the operating room, you'll recognize scopolamine as the little patch people wear behind their ear before a cruise. That same transdermal patch, delivering about 1.5 milligrams over 72 hours, gets used perioperatively too, cutting down the rate and severity of post-op nausea and vomiting for the full 3 days it's worn. It's particularly useful for patients you already know are at high risk for PONV, or anyone prone to motion sickness. Effects on the brain. Because scopolamine gets into the CNS so readily, its brain effects go beyond simple drowsiness. When used intravenously, most patients get calm and sedated, with real amnesia to show for it. But some patients, particularly older adults, swing the other direction entirely, becoming restless, confused, or even hallucinating. If a patient wakes up unusually agitated, or takes an unusually long time to wake up at all, and they received scopolamine, that's worth considering as the explanation. Volatile anesthetics can make these central effects even more pronounced, raising the odds of postoperative restlessness or excessive sleepiness. If you need to reverse it, physostigmine, 2 milligrams IV, works well and may need repeating every 1 to 2 hours, since its own effect wears off relatively fast. The eyes. Scopolamine dilates the pupil and paralyzes the ability to focus up close, mydriasis and cycloplegia. The mechanism traces back to the third cranial nerve, which carries cholinergic fibers to 2 separate eye muscles, one that constricts the pupil and one that lets the lens curve for near vision. Block acetylcholine at both sites, and you lose pupil constriction and the ability to focus on close objects simultaneously. Scopolamine actually dilates the pupil more aggressively than atropine does, which means extra caution is warranted in anyone with narrow-angle glaucoma. If you ever need to reverse that dilation locally, a topical cholinesterase inhibitor like pilocarpine will do the job. When the brain gets too much, central anticholinergic syndrome. This is where scopolamine's CNS penetration becomes a genuine clinical problem rather than a therapeutic feature. Give enough of it, or give it to a susceptible patient, and you can push someone into a spectrum of symptoms ranging from restless agitation and hallucinations all the way to somnolence and unresponsiveness. Atropine can occasionally cause this too, though far less often. Scopolamine is the more frequent culprit, simply because so much more of it reaches the brain. The fix is physostigmine, 15 to 60 micrograms per kilogram IV. The reason physostigmine works where other reversal agents fail comes back to the same structural theme we started with. Physostigmine is itself a lipid-soluble tertiary amine, so it can cross into the CNS and restore the acetylcholine activity that scopolamine blocked. Neostigmine cannot do this job. It's a quaternary amine, charged and unable to cross the blood-brain barrier, so it has zero effect on central anticholinergic symptoms, no matter how much you give. Because physostigmine gets cleared fairly quickly, expect to redose it every 1 to 2 hours if symptoms return. When someone takes too much, anticholinergic overdose produces a recognizable cluster of findings, one most people learn as a memorable rhyme: dry as a bone, parched mouth, trouble swallowing and speaking, blind as a bat, blurred vision, light sensitivity, wide open pupils, red as a beet, flushed skin, especially across the face, neck, and upper chest, hot as a hair, elevated body temperature. This last one deserves its own explanation. Sweat glands are innervated by sympathetic nerves, but unusually, those particular nerves release acetylcholine rather than norepinephrine. Block that acetylcholine and sweating stops, which is why body temperature climbs, especially in a warm room. Small children are especially vulnerable here, occasionally developing what's been called atropine fever, even from a standard therapeutic dose. Mad as a hatter, agitation, hallucinations, delirium, seizures, progressing to coma in severe cases. And full, urinary retention. You'll also often see tachycardia and sometimes a slight rise in minute ventilation, partly from CNS stimulation and partly because bronchodilation increases physiologic dead space. Arterial blood gases usually stay normal. If muscle weakness or orthostatic hypotension appear, that points toward nicotinic receptor involvement at very high doses. In truly severe overdoses, seizures, coma, and paralysis of the medullary breathing center can be fatal. Treatment is the same physostigmine dose, 15 to 60 micrograms per kilogram IV, with supportive care and repeat dosing as needed, since physostigmine doesn't last long.
Who should avoid this drug?
Steer clear entirely in narrow-angle glaucoma, known hypersensitivity. Use caution with significant tachyarrhythmias, mechanical bowel obstruction, and myasthenia gravis, enlarged prostate, existing heart disease, elderly patients, young children, and anyone already on another anticholinergic. Putting the three anticholinergics side by side. This comparison shows up constantly on exams, so it's worth locking in. Sedation, scopolamine is strongest, atropine is mild, glycopyrrolate essentially does nothing here, which tracks perfectly with how well each drug crosses into the brain. Heart rate, flip the ranking. Atropine raises it the most, glycopyrrolate moderately, scopolamine only mildly. Despite being the weakest CNS penetrators opposite, atropine turns out to be the strongest cardiac agent. Drying secretions. Scopolamine and glycopyrrolate are both strong here, atropine comparatively weak. The 5 things to walk away with. 1. It's a natural alkaloid from belladonna, also called hyoscine, and its lipid-soluble tertiary amine structure explains its entire clinical profile. 2. It's roughly 100 times more potent than atropine at suppressing the reticular activating system, making it the only anticholinergic that reliably sedates. 3. It outdries atropine 3-fold for secretions, while causing less tachycardia at matched doses, a genuinely counterintuitive pairing. 4. Central anticholinergic syndrome responds only to physostigmine, because it alone can cross into the brain. Neostigmine cannot touch it. 5. Oral dosing is never used because absorption is completely unreliable. Understand the chemistry. Lipid-soluble, tertiary amine crosses into the brain, and every other fact about this drug falls into place without needing to be memorized as a disconnected list. I'm Anesthesia Buddy. Stay sharp. See you in the next one.